Good afternoon to everyone joining us for today's webinar on non-invasive ventilation. My name is Brkic George, Product Manager from Heyer Medical, and I'm delighted to welcome our expert, Dr. Mark Elliott from UK, as our key speaker today. Dr. Mark Elliott is a retired consultant physician in respiratory medicine at St. James University Hospital, Leeds, and he has been responsible for developing the home sleep and assisted ventilation service for acute in-hospital non-invasive ventilation and weaning of patients with prolonged ventilator dependence at St. James University Hospital. He has research interests in acute and chronic non-invasive and obstructive sleep apnea. Dr. Elliott was also president of the British Thoracic Society from 2018 to 2019, and he was also treasurer of the European Respiratory Society from 2013 to 2016. He was as well a core member of the guidelines writing group for both the BTS and ERS-ATS acute non-invasive guidelines, as well as the ERS guidelines on the long-term for home non-invasive ventilation for management of the COPD. Today, he's going to talk about the non-invasive ventilation in acute hypercapnic respiratory failure. And as a small reminder, your microphones and cameras for today's sessions are switched off, but you can use Q&A function to ask all the questions, which will be answered in the last sections of today's webinar. Now, let us all listen to the lecture of Dr. Elliott.
Thanks very much for asking me to give this talk. I understand that some of you are not routinely using non-invasive ventilation as part of your everyday clinical practice. And so my job today is to explain to you the evidence behind why I think you should be. I'm going to focus exclusively on its use in acute hypercapnic respiratory failure. NIV does have a role in patients with hypoxemic respiratory failure, but the evidence is less strong and they represent a much greater challenge. So I think if you're not doing this regularly, where you need to be starting is with the hypercapnic patients. The first point to make is that non-invasive ventilation is not conceptually different to invasive ventilation. This is an early study from Stefano Nava published back in 2001 in which they compared various physiological parameters during both invasive and non-invasive ventilation. And the take-home message is that both in terms of blood gases shown here, there is absolutely no difference when ventilation is delivered non-invasively as compared to invasively, and you can see the numbers for yourself there. When we look at the effect on work of breathing, we see exactly the same thing, that the reduction in the pressure time product of the diaphragm, a measure of the work of breathing, is exactly the same whether you use ventilation non-invasively or invasively. So the important thing to note is that the key difference here is the interface. It is not a difference in ventilation per se. There is a second important follow-on from this, and that is that ventilatory support need not be continuous. With non-invasive ventilation, it is very easy to remove the mask, to put it back on again, to provide ventilatory support on an intermittent basis, whereas this is much more difficult and certainly much more uncomfortable if you have an intubated ventilated patient. So the key difference is the interface, and this is something that we will return to intermittently during the course of this talk. Before we go on to look at non-invasive ventilation in more detail, I would just like to spend a couple of moments exploring the pathophysiology of ventilatory failure. And when dealing with patients with hypercapnic respiratory failure, I find it very helpful to analyze this in terms of abnormalities of load, capacity, and drive. And I think this is best illustrated by thinking about what may prevent you from carrying a heavy suitcase from point A to point B. The first thing is that it may be an extremely heavy suitcase that nobody can carry. An example of this in the respiratory context would be somebody with status asthmaticus. It doesn't matter what the situation, you just have a load that is so great that nobody is going to be able to sustain effective ventilation. The second reason that we may not be able to carry the suitcase is that we may be too weak. So there's one person who's a bit stronger can manage it without any difficulty, but I'm just too weak to carry it. And an example of this would be the patient with ALS, motor neurone disease. There's nothing wrong with the lungs. The problem is that the respiratory muscle pump is just so weak that it cannot sustain ventilation, even with normal lungs. And then the third reason is an abnormality of drive. The suitcase is not particularly heavy. I'm strong enough, but I just can't be bothered. And an example of this would be a patient who's been given too much of a respiratory suppressing drug, e.g. opiates, or has an abnormality of central drive due to a neurological problem. These can occur alone or more often in combination. I think it's important then to realize that when you add them together, the sum of the parts may be greater than you would expect from any one individually. So for instance, a patient with severe COPD, in which the primary abnormality is an increased load, but there is also an abnormality of capacity, may be tipped over into respiratory failure by a tiny dose of a sedative drug. This next slide shows how these various factors can interact in a patient with an acute exacerbation of COPD. The primary abnormality is of airways disease, and this increases load by increasing airflow obstruction and also frequently excessive secretion production. However, hyperinflation, a consequence of airways disease, reduces the mechanical advantage of both the intercostal muscles and the diaphragm, so that you have a secondary reduction in capacity. It's not that the muscles per se are weak, though of course they may be weakened a little bit by constant steroid usage, malnutrition, etc. But just the simple fact that you now have a diaphragm that is horizontal rather than domed means that when it contracts, instead of producing pressure and volume change, it simply just shortens. So you've got reduced capacity. The increased load, the reduced capacity, results in abnormal blood gas tensions, and we know that due to effects on the kidney, this can cause fluid retention, which makes the lungs stiffer, further increasing the load. If the CO2 goes very high, you get a reduction in drive, which further worsens the abnormal arterial blood gas tensions. An increased load increases sleep deprivation, which can also reduce respiratory drive. And what you can see here is that you have a number of self-perpetuating vicious cycles, so that once they start, a patient can fairly rapidly spiral down into severe hypercapnic respiratory failure. The good news is that if you can begin to reverse these, you can then have a virtuous cycle. So for instance, if using a ventilator, you take some of the load, you can reduce the respiratory rate, which allows greater time for lung emptying. So hyperinflation is reduced, which now starts to improve respiratory muscle capacity, which can now feed back into improving arterial blood gas tensions because it's better able to cope with the increased load. The patient starts to pass urine, further reduction in load, etc., etc. So I think this is a very useful way of understanding and analyzing respiratory failure. And this sort of analysis holds good regardless of the cause of the primary cause of the respiratory failure. So this is from a table taken from an article that I wrote a few years ago, and I'll give you the reference to it at the end. But basically what I've done here is to look at two conditions, motor neurone disease, ALS, and COPD, and just looked at the primary consequences in terms of load, drive, and capacity, the consequences that can develop secondarily. So for instance, in the motor neurone disease patient, the load is unchanged normally, but can be increased if they get excessive secretions due to a chest infection, etc., etc. And then the implications for non-invasive ventilation. What do you need to do to counterbalance these various abnormalities? And I'd encourage you to look at that if you're interested. And as I say, I'll give you the reference at the end. So let's go on to explore the evidence for the use of NIV in exacerbations of COPD. And I want to look at three important studies that were all published over 20 years ago. The first was this study by Laurent Brochard and co-workers published in the New England Journal. They compared standard therapy versus non-invasive ventilation in an intensive care setting. There were 42 patients, 42 versus 43 patients. These patients all had a moderately severe acidosis and were tachypneic. These are the results. There was a marked reduction in the intubation rate, 26% in the patients randomized to non-invasive ventilation versus 74% in those randomized to conventional therapy. This translated into an improved survival with 9% mortality in the NIV group compared to just under 30% in the invasively ventilated group. There was a reduction in the length of stay in hospital from 35 days on average in the invasively ventilated group to 23 days in the non-invasively ventilated group, which would translate into a very substantial cost saving. And there was a marked reduction in the complication rate. And indeed, all the excess complications that were seen were in the intubated patients. In other words, were a consequence of intubation. So by solving one problem, one created another. So the act of intubation and leaving a patient intubated creates its own problems while solving the problem of the respiratory failure. It's important to note that this was done getting on for 30 years ago now, at a time when the whole technology was much less well developed than it is today. And this was the sort of interface that was used together with an insert to reduce the dead space. We now think that dead space, particularly with modern ventilators, is much less of a problem. The ventilator on the other end was just an old-fashioned servo C ventilator, and subsequent studies have shown that ITU ventilators are much less effective at dealing with leaks and generally less good for non-invasive ventilation than a purpose-built non-invasive ventilator. So these results were achieved with old-fashioned interfaces and old-fashioned ventilators, but showing a very clear advantage in this group of patients to the non-invasive approach. This whole issue of infections is interesting. This is a follow-on study that again came from Laurent Brochard's group, but the first author, Emmanuel Giroux. And this is just looking at the frequency of nosocomial infections in the two groups. And what you can see is that there is a very marked reduction, but this is not just in terms of reduction in pneumonia, but also in urinary tract infections and catheter-related infections. And one of the problems with invasive ventilation that it brings with it not just the endotracheal tube, but usually a urinary catheter, arterial lines, a central line, etc., etc. And these all increase the risk of nosocomial infection. We know that for every day ventilated, intubated and ventilated, a patient has a 1% risk of developing ventilator-associated pneumonia, which both prolongs ICU stay, but also reduces survival. The second study is this study from our group here in Yorkshire, published in the Lancet. And what we did here was we took patients with less severe respiratory failure. And importantly, these patients received non-invasive ventilation on a general medical ward. So the first study, the Brochard study, was done in the intensive care unit. This is now being done in a general ward, which has important implications for the way that this technology can be implemented. And again, we saw a substantial advantage to non-invasive ventilation. We used the primary endpoint was a priori defined criteria for failure of medical therapy, and you can see that this resulted in a highly statistically significant reduction in the number of patients failing. This in turn translated into a non-significant reduction in intensive care unit stay, but again a statistically significant reduction in the number of deaths. And you can see here the risk reductions of about 50%. Important to look at these patients by enrollment pH. These results are not statistically significant because the study lacked adequate power, but the findings have been borne out in later studies, that what we found here was that the pH less than 7.3, that although there was a substantial advantage to non-invasive ventilation compared with invasive ventilation, the sorts of results that we were achieving in the general ward setting were still not nearly as good as if it could be achieved in the ICU setting. So this is pH less than 7.3. You'll remember that the Brochard study pHs were around about 7.27, 7.28, and their mortality in the NIV group was about 10%, whereas ours was about 20%. Whereas when you look at the group with a pH greater than 7.3, you can see that the results now are much more acceptable. So overall, non-invasive ventilation less failure and death than invasive ventilation, but the results achieved on the general ward not as good as those received in the intensive care unit. And I don't think we should immediately be saying that all these patients now should be on intensive care. It depends very much on the model of care in your country, and important to realise that this was in the very early days of non-invasive ventilation, and much better results have now been presented with more modern interfaces, more modern ventilators, and importantly, much greater understanding, experience, and training in the whole field of the delivery of acute non-invasive ventilation. But I think it's important still to remember that patients with a pH of less than 7.3 are a significantly higher risk group than those with a pH of greater than 7.3. This was the ventilator that we used, and again, important to note that it's an old-fashioned machine. It was designed for home use, so you set the ventilator with this external module, the idea being that you did this in hospital and you disconnected it, sending the patient home with the ventilator unit. Complicated to navigate the menu, but also a technically much inferior ventilator to the sorts of machines that we're using today. Also, the range of interfaces that were available was much less than we have today, and the materials from which these were made, the assortment of shapes and sizes, things have come a long way since these days. So these big reductions in failed therapy, improvements in survival, were achieved both with a very old-fashioned ventilator, but also some very inferior masks compared to those that are now available. The third study is this one from Giorgio Conti and co-workers from Italy, in which they compared non-invasive with invasive ventilation in a head-to-head comparison. So they were faced with a patient where a decision had been made that this patient needs to be intubated, and at that point they were randomized either to NIV or to invasive ventilation. And the important take-home message from this study is that non-invasive ventilation was no worse than invasive ventilation. This is very important because there had been a number of studies, or one or two studies, that had suggested a worse outcome in patients receiving NIV, and it was attributed to delays in intubation. This study showed no difference in length of ICU stay, number of days on mechanical ventilation, complication rates, ICU or hospital mortality. But what it did show was that in the year following this episode, there was a clear advantage to the non-invasively group, non-ventilated group. That they had fewer patients readmitted to hospital or requiring de novo permanent oxygen supplementation. And you'll all be familiar with the patient with COPD who has a prolonged ICU stay, and it takes them a very considerable length of time to get back to baseline, if indeed they ever achieve that. Important to note that in the patients who could be successfully managed with non-invasive ventilation, they had a shorter duration of ICU stay than the intubated patients. But the key take-home message is non-invasive ventilation no worse than invasive ventilation compared head-to-head, and clear longer-term advantages to the non-invasive group. Since those early studies, there have been a large number of randomized controlled trials from different countries performed in different settings in different subgroups of patients with exacerbations of COPD. This is the forest plot from the ERS-ATS guideline published in 2017, and you can see here that overall there is a clear advantage to non-invasive ventilation. Importantly, there is not one study showing that non-invasive ventilation was worse, with most showing an advantage. These studies here, in which there is no obvious advantage, were in the intubated patients, so that's similar with the Conti study. And then here, these are in patients who were not acidotic at the time of randomization. And that's really not surprising. These are a very low risk group. So importantly, no studies going on from those early studies showing really different results to what those early studies showed. So I think we have a pretty clear idea now of how NIV should be used in exacerbations of COPD. I think the first and most important thing, and I haven't spoken about this up to now, but it's very important, is that one must get controlled oxygen therapy right. There are clearly a subgroup of patients with exacerbation of COPD who end up in respiratory failure purely because they've been given too much oxygen. And therefore, we would always advocate a period of time on low flow oxygen targeting oxygen saturations of 88 to 92%, or using a 24% Venturi mask. Also important not to neglect other aspects of medical therapy. And then after approximately an hour, time interval to be determined a bit by the severity of the pH at baseline, we repeat the blood gases. If the pH is less than 7.35, we can say that non-invasive ventilation is advised, and this is on the basis of the Ioniv study. But we have to remember that 80% of patients are going to get better anyway. And so if your patient is one of those who's not really coping with non-invasive ventilation and the pH is above 7.30, it's not but less than 7.35, it's not unreasonable just to see, are they part of the 80% who's going to get better anyway, and to repeat the blood gases. Once the pH drops below 7.3, we can say that NIV is strongly advised, because without it, approximately 50% of them are going to get worse to the point where endotracheal intubation is needed, or indeed they may die. And then once the pH drops down below 7.2, we're really falling into a much higher risk group, where we have to accept that there is a greater risk of failure. But even so, there is no lower limit of pH beyond which a trial of non-invasive ventilation is not indicated. And there have been a number of studies showing patients with really very severe acidosis who can be successfully ventilated. I think the key thing in the very sick patients is that one shouldn't be engaging in a prolonged trial of non-invasive ventilation. But if you think back to that slide I showed of the various interacting vicious cycles, these patients can actually start to pick up remarkably quickly. So what are the contraindications? Well, I think it's true to say that there are a few absolute contraindications, that those quoted were usually exclusion criteria for the randomized controlled trials, rather than things that had been shown to be harmful. Indeed, some in subsequent studies have been shown to be incorrect. So for instance, coma. This was an exclusion criterion for inclusion within the trials, but there's a study from Spain and other centres showing that patients with coma actually do very well. The problem starts to be when they wake up and they begin to they're confused and they're not quite sure what's happening, and they begin to struggle. But coma per se is not a reason for avoiding non-invasive ventilation. There is little to be lost by a trial of NIV in most situations, as I've said before, and I think one has to accept that there are things that make NIV more difficult, and these include confusion, excessive secretions. But again, in dealing with the latter, the intermittent nature of non-invasive ventilation can be an advantage, in that these patients can come off the ventilator to participate in effective physiotherapy to reduce the secretion burden, etc. It all depends on whether endotracheal intubation is deemed appropriate or not, and if it's not, then there is absolutely nothing to be lost, as the alternative is doing nothing. But I think in somebody who would have a very low threshold for intubating, then obviously it's going to change how long you persist with NIV. Obviously, if you can't fit an interface, that is going to be a contraindication. It's very important to appreciate that non-invasive ventilation isn't going to be effective in every patient, and we need to monitor them. This is looking at the Aeoniv data set, looking at predictors of failure. It was done at 4 hours. That's because in that study, that was the time that we chose to do the repeat blood gas. The exact timing is not important. What is important is the key take-home message. And what you can see here in this table is that we've taken the pH at time 0, the respiratory rate at time 0, and we have compared these variables with the values that we have at 4 minutes. So if they're unchanged, you've got an initial pH which is not changed, the respiratory rate, and we've given that a relative risk of 1. If one thing gets better and the other stays the same, so let's stay on this line here, the pH is staying the same, but the respiratory rate is falling, the risk of failure is reducing. If the pH stays the same, but the respiratory rate goes up, the risk of failure increases. If both increase, the risk goes up markedly. If both improve, so respiratory rate coming down, pH improving, then the risk of failure is markedly reduced. And wherever you start on this table, the same relationships hold true. So, two things that are easily measured, respiratory rate and pH. If one the same, one getting better, you're probably going to be okay. If both getting better, you're almost certainly going to be okay. If one or both getting worse, then your chances of survival reduce, chances of failure increased. But what exactly is failure of non-invasive ventilation? This is a study that was published in the Blue Journal looking at a very large data set, 7 million episodes if I remember rightly, and they looked at a number of different factors over the year that had impacted on outcomes in patients admitted to hospital with acute exacerbations of COPD. And generally speaking, there had been small but significant improvements in outcome. One group in whom things had definitely got worse was the patients who initially received non-invasive ventilation but then transitioned to invasive ventilation. And that's this group here, where you can see that there's been actually quite a substantial worsening in outcome in the 10 years between 1997 and 2007. And the authors attributed this to a delay in intubation. Now, Stefano Nava and I wrote an editorial that accompanied this, and we postulated the possibility of another reason why we might be seeing this, and that is that it might be that the patient who is failing with non-invasive ventilation is a patient who is difficult to ventilate and is going to fail regardless of what you do. And I think it's very important to understand failure of non-invasive ventilation. Firstly, in terms of failure of the non-invasive bit, in other words, this is a failure of to tolerate or to get an acceptable fit of the interface. This tends to be early. There aren't patients who you can initially get a good fit with an interface that's well tolerated, that subsequently the patient doesn't get on with it. At this point, you've still got time for medical therapy to work, but perhaps most importantly, that substituting a different sort of interface, namely an endotracheal tube, for one that isn't working, brings with it a chance that this intervention is going to be successful. If you contrast that with failure of ventilation, and by this I mean the patient for whom the interface is well fitted, there isn't much leak, the patient is tolerating it well, and yet despite this, the patient is not getting better. In other words, it's the ventilation bit that's the problem. This tends to occur later. Medical therapy has already had its chance, but most importantly, substituting an interface that's working pretty well with another interface that does much the same isn't probably going to make any big difference, so one would expect less success from the invasive approach. I think it's very important that when we think about the failure of the application of NIV due to poor tolerance, that we don't immediately blame the patient, that sometimes the patient is absolutely right not to tolerate non-invasive ventilation. The interface that they've been given is inappropriate, it's poorly fitting, it's uncomfortable. Ventilator settings are inappropriate to their needs. In fact, things are making them worse, and it's not surprising, therefore, that they won't put up with it. So before you blame the patient and say that it's their fault that they're not tolerating NIV, make sure that we've got everything right that we can. This is going back to Laurent Brochard's study, and you can see here some, I think, evidence that in part supports what I've just been saying, and that is that the major benefit of non-invasive ventilation is occurring in the early stages. So this is the timing of endotracheal intubation, and what you can see here is that there is a very big advantage to non-invasive ventilation in the early stages, whereas in the later stages there is no significant difference. This is an audit that was produced by the British Thoracic Society that was published back in 2011. There were lots of messages from this audit, but the one that I want to focus on here is really the impact of the timing of acidosis. What you can see here is that we have three groups of patients. The first is those who are acidotic on admission, this being the lowest pH. The second is those who were acidotic on admission, but a later pH was worse. And this is a third group who weren't acidotic when they were first admitted to hospital, but became acidotic during their admission. And what we can see is that these two groups had a significantly worse outcome compared with group 1. So the point in time at which patients become acidotic, or if there is evidence that they're getting more acidotic, has an impact on the likely outcome from ventilatory support and indeed from medical therapy per se, and is a factor that should be taken into account in our decision-making processes. So what do we do when the patient is failing? And I think, again, this is an important consideration, because in the studies that failure was it. The patient was removed from the study. They were deemed to have failed with non-invasive ventilation. But everyday clinical practice, it's not quite like that. Yes, of course, you can intubate them, but you can change the settings. You can increase the level of ventilatory support. You can change the interface. Unusual to change from a full face mask to a nasal mask, but just occasionally that can do the trick. But certainly trying a different sort of full face mask, if you're not achieving a good sale with the one that you're using, might make all the difference. It's also important to appreciate that we are usually dealing with patients with an acute on chronic condition. And in some situations, it may be more appropriate to consider a palliative approach. And I think that this is a very important place where non-invasive ventilation can have a much bigger role than when your only option is invasive ventilation. I don't often read obituaries, but whenever I do, I find them always interesting and inspiring. And this is one from the BMJ, the British Medical Journal, that was published many years ago about a general practitioner called Kieran Sweeney, who was an academic GP who died of mesothelioma. And I just want to read one part of this, really word for word, because I think it's really important. They had proposed a third hurdle of significance to kick in if the first two hurdles of statistical significance, is it real, and clinical significance, does it matter, are satisfied. An action would achieve personal significance if it took into account the experience of this particular patient's suffering, style, circumstances, and beliefs. Then and only then go and do it. He later described this approach as metaphysical, and in a prescient piece he wrote, "The clearest examples of this transition to the metaphysical level occur when someone starts to die or accepts that death is near. Here, both the doctor and the patient are confronted by the question, when is enough enough? This, he wrote, will be the defining question for the next generation of practitioners. I think he was absolutely right. I found in my clinical practice that increasingly it became dominated by considerations of this sort. Patients on their third, fourth, fifth exacerbation. When is enough enough? When do we just have to accept that we are interfering with the natural process of a patient dying rather than prolonging meaningful life? And I think NIV provides a very useful tool in this situation, because what we face in terms of palliative care is not the previous models of curative, restorative care, abruptly transitioning into palliative care. An example of this would be the patient with lung cancer who has a pneumonectomy. The sole aim is to try and cure. They represent with cerebral metastases. There is no chance of cure. It's pure palliation. Very clear delineation between the two. Other patients with chronic disease, one faced with a fairly clear change over time of moving to more palliative approach. But what we face in patients with the acute exacerbation of COPD is this sort of pattern, where the patient on an hour by hour, let alone day by day basis, can fluctuate between us thinking that things are going well, they're improving, we should be going for a more curative approach, things aren't going so well, we need to palliate. And we've all seen the patient with COPD who we thought wasn't going to make it through the night, who the next morning is up having their breakfast, asking when they can go home. And I think NIV provides a very useful strategy here, in that you can back both horses, in that it provides both life-sustaining therapy but also effective palliation. And this is a study from Stefano Nava, again, just showing that NIV results in more effective palliation and breathlessness than conventional therapy, and importantly, a reduction in the requirement for opiates. So where are we with acute exacerbations of COPD? I think NIV is the standard of care for most patients with acidotic hypercapnic ventilatory failure due to an exacerbation of COPD. It's indicated when the pH is less than 7.35 after initial management, but we mustn't forget the importance of the significance for pH less than 7.3, and in particular the importance of controlled oxygen therapy. Well, what about other patients with airways disease? NIV should not be used in the vast majority of acute asthma attacks, the exception being those who with fixed airways disease who are behaving more like patients with chronic obstructive pulmonary disease. But the evidence base for this is extremely weak. In patients with bronchiectasis, again, there are no randomized controlled trials, but there are reasonable theoretical considerations for thinking that it might work in the same way as it does in COPD, as the underlying physiology is much the same. And I think it's entirely reasonable to follow the same guidance as we use for COPD. What about obesity? This is certainly becoming a much more common problem in our practice in the UK. There are no randomized controlled trials, but I think that there is a lot of anecdotal evidence that these patients do very badly with invasive ventilation and do well with non-invasive ventilation. I think we probably should use the same criteria as we use for COPD, with the exception that a raised CO2 without acidosis may be an indication in that these patients are probably going to need some form of long-term ventilatory support. I haven't got time to go into it now, but I think the vast majority of them can be managed with CPAP longer term, but in the short term in a hospital, bringing about a more rapid improvement in CO2 with non-invasive ventilation, even if they're not acidotic, is probably advantageous. Useful to sit these patients up because they have a very high impedance to inflation, and getting gravity on your side, getting that large abdomen out of the way. Occasionally need to use volume ventilators or volume assured modes. We mustn't forget the upper airway obstruction, and so sometimes one needs to use different levels of EPAP when the patient is asleep and when they're awake. So at night you have a higher level of EPAP, sacrificing the level of pressure support to bring about control of the upper airway, whereas when the patient is awake, this is no longer an issue, and you can reduce the level of EPAP, giving them a higher effective level of pressure support. We shouldn't forget fluid overload. It can be very difficult to detect this in these very overweight patients, and I always work on the principle of if in doubt, dry them out. And we need to remember that hypercapnia during admission is a poor prognostic sign, and that these patients definitely need to be under long-term follow-up, and a significant proportion will need respiratory support. Neuromuscular disease, scoliosis. Again, we shouldn't wait for them to become acidotic, particularly the patients with neuromuscular disease, but by the time they become hypercapnic, unless there is a very significant other factor, increasing load, etc. If it's just due to the respiratory muscle weakness, this is very advanced, and these patients are in a very precarious position and are almost always, in fact, always going to need long-term ventilatory support, and there is absolutely no reason to delay getting on instituting it. I would take it one stage further and say that patients who are normocapnic with a reduced vital capacity and tachypnea, that they can't sustain this forever, and that these patients will fairly rapidly become hypercapnic. So you may wish to consider it even in the non-hypercapnic patient. Again, a number of other things that we shouldn't forget. Upper airway obstruction can be prominent in some patients with neuromuscular disease, and certainly in some scoliosis patients because of their abnormal anatomy. Problems with the upper airway can lead to recurrent aspiration. A proportion of patients with generalized muscle problems that the heart is involved, so always consider the possibility of coexistent cardiac disease. And don't forget that these patients have significant problems with their expiratory muscles also, and therefore of clearing excessive secretions, and the cough assist device can be very helpful. So why should NIV be considered for certain hypercapnic patients? And I think the answer is very simple, that in certain circumstances it is better than invasive ventilation. We've seen it's physiologically no different. We've seen improved survival. We've seen reduced nosocomial infections and not just respiratory ones. We've seen lower lengths of stay, which translate into cost savings. And I think it also increases access. We saw this during the COVID epidemic, where the ability to provide non-invasive ventilatory support meant that it was possible to ventilate more patients needing intermediate levels of support than would have been the case if one was just able to offer invasive ventilation. But I think in the hypercapnic group, it's very important as having it an option in those who are marginal for escalation to intubation. It's much easier to manage these patients non-invasively. You can involve them in discussions about their own treatment. It buys some time to discuss things further, to see how things are going. And I think it can improve end-of-life care. So in finishing, it's important to stress that non-invasive ventilation does not replace invasive ventilation. It is complementary, not a competitor. I'd like to draw your attention to these two sets of guidelines from the European Respiratory Society and ATS and the British Thoracic Society. They're slightly different in their approach, but they're complementary and are an excellent resource. I presented a table earlier, and it was taken from this article in Respirology, in which I outlined the essential requirements and clinical skills necessary for successful practice, and I would commend that article to you. It was one I very much enjoyed writing, and I think a number of people have told me how useful they found it. So if you're interested in all of this and want to take it further, there's some useful information there. So thanks very much for your attention.
Thanks to Dr. Elliott for a lecture on the topic of the non-invasive ventilation in acute hypercapnic respiratory failure. I would like to remind our participants that the Q&A function is open and that you can post your questions at any moment. However, before proceeding to our Q&A sessions, allow us to introduce Heyer VG55 non-invasive ventilator. This is the third part of today's webinar, and now we are going to introduce our Heyer VG55 non-invasive ventilator. First of all, we would like to say that this is ventilator that is specialized exclusively in the non-invasive ventilation in order to address the need for effective respiratory support while minimizing the risks associated with invasive procedures. What you need to know is that this ventilator can deliver tidal volumes ranging from 50 to 2,500 milliliters, which makes it suitable for non-invasive therapy of pediatric and adult patients. Finally, in this device, we implement the German technology developed by Heyer Medical. Heyer VG55 comes with the built-in low noise and long lifetime turbine, and therefore eliminates the need for the air compressor in order to provide air for this device. On the other side, in the terms of providing oxygen or compressed oxygen to this device, we have few options. Either we can choose the high flow, for which we will provide oxygen through the cylinder or the central gas supply system, or we can choose the low flow option, where we can provide oxygen from the oxygen concentrator or oxygen generator. Thanks to this kind of arrangement, the scope of application of this device is quite wide. We can use this device in preparation room, clinic, general wards, as well as in emergency room and intensive care units. Now let's have a look on the configuration of the VG55. We can separate it into three parts: main control unit, trolley, and accessories. Main control unit comes in the two parts: ventilator host and the display screen. The display screen is 15.6 inches capacitive touchscreen that has capability to rotate up and down and left to right up to 90 degrees. This main control unit is mounted on the trolley, and thanks to the elimination of need for air compressor, this device can be easily moved inside or outside of the hospital. Finally, in the terms of the accessories, we have standard and optional accessories. From standard accessories, we have the single limb patient circuit, pressure sampling kit, mechanical arm on which we'll position our patient circuit, humidifier, and also mask with intentional leakage. In terms of the optional features, we provide SpO2 monitoring module for monitoring of the SpO2 and the pulse rate, as well as the possibility to install cylinder holder on the back of the trolley and mount cylinders on that location. Non-invasive ventilation is effective in managing various respiratory conditions, such as exacerbation of chronic obstructive pulmonary disease, congestive heart failure, and acute respiratory failure. Therefore, in Heyer VG55, we include complete set of the ventilation modes that are specialized in non-invasive ventilation. We have continuous positive airway pressure ventilation, continuous time ventilation, time switch ventilation, and also volume guaranteed pressure support ventilation. In CPAP, or continuous positive airway pressure mode, the ventilator operates as a demand flow system, keeping the constant airway pressure in form of CPAP while the patient independently initiates all breaths and defines their rhythm and magnitude. Pressure reduction at the initiation of the exhalation, known as C relief, takes the conventional CPAP approach a step further. This modification directly addresses a common issue faced by CPAP users, significantly reducing the discomfort experience during this phase, therefore significantly enhancing patient comfort and overall compliance. The extent of the pressure alleviation is finely tuned through the C relief setting and is also influenced by the expiratory flow rate. By adjusting the setting number between 0, 1, and 3, in conjunction with an enhanced expiratory flow, patients can experience a more pronounced pressure relief effect. This personalized approach not only caters to individual needs and ensures a smoother experience, but also maximizes therapeutic effectiveness. Spontaneous timed ventilation mode, or ST mode, brings the advantage of maintaining a consistent gas delivery frequency as per the predetermined settings, promoting stability in the patient's breathing pattern. This mode not only ensures that the ventilator takes charge of pressure control and timing for mandatory breaths, but also provides assistance for spontaneous breaths, offering patients a more natural and comfortable breathing experience. With ST mode, the pressure aligns precisely with the preset IPAP value, optimizing respiratory support tailored to individual needs. For patients who may experience difficulty initiating breaths at the designated frequency interval, the ventilator takes the initiative to trigger mandatory breaths in line with the preset T inspiratory value, safeguarding their respiratory well-being. Conversely, when patients do initiate breaths, the ventilator intelligently responds to the preset trigger value, facilitating smoother transitions between inhalation and exhalation. This not only ensures optimal ventilation, but also contributes to patient comfort and overall respiratory efficiency. In time switch ventilation, or T mode, we offer straightforward approach to respiratory support. In this mode, the ventilator focuses exclusively on providing pressure-controlled mandatory ventilation, relieving patients of the need to initiate breaths themselves. The parameters for pressure, frequency, and inspiratory time are automatically synchronized with the preset settings for IPAP, frequency, and inspiratory time. This mode can be particularly beneficial for patients who might have difficulty triggering breaths consistently. By taking the responsibility of breath initiation, T mode ensures that patients receive by delivering consistent, timed breaths. T mode aids in maintaining adequate oxygenation and ventilation levels, ultimately contributing to the better respiratory efficiency and overall comfort. In volume guaranteed pressure support ventilation mode, or VGPS mode, the ventilator ensures a specific tidal volume by adjusting pressure and following the predetermined T inspiratory setting. In this mode, the ventilator manages both mandatory breaths based on timing and assists spontaneous breaths with the pressure support. When patients do not initiate breaths within the predetermined frequency interval, the ventilator takes the initiative to trigger and deliver breaths according to the preset time inspiratory value. Conversely, if patient triggers the ventilator within the interval, the ventilator adapts to the preset trigger value, monitors expiratory efforts, and smoothly transitions to exhalation. By providing a consistent and objective tidal volume, this mode helps maintain optimal respiratory function. Patients who struggle to initiate breaths at the specific frequency can rely on ventilator to ensure regular ventilation, promoting proper oxygenation. Similarly, patients who are able to trigger breaths benefit from a personalized experience as the ventilator responds to their respiratory efforts. The mode's ability to adjust breath cycles based on pressure settings like P max and P minimum allows for fine-tuning according to individual needs. Over time, this mode's adjustments contribute to achieving the preset tidal. High flow therapy mode in VG55 is a sophisticated approach designed to optimize respiratory support for patients. By delivering precisely heated and humidified mixture of air and oxygen at an elevated flow rate up to 50 liters per minute, this mode confers multiple patients benefits. It alleviates the work of breathing, augments oxygenation, and reduces airway resistance, rendering it particularly advantageous for individuals grappling with conditions ranging from respiratory muscle fatigue to obstructive airway diseases. The therapy's provision of positive airway pressure enhances lung mechanics and secretion clearance, contributing to enhanced ventilation and overall lung hygiene. Ultimately, high-flow therapy's versatile application, improved patient compliance, and potential to avert intubation underscore its pivotal role in modern non-invasive ventilation strategies. In the tone of today's webinar topic, uh, as a conclusion of today's product presentation, we'll go once again through the reasons why it is recommended to choose non-invasive ventilation and the non-invasive ventilator. First reason is reduced risk of infections. Non-invasive ventilation eliminates the need for invasive procedures like endotracheal intubation, therefore significantly lowering the risk of the ventilator-associated infections and complications. Another benefit is preservation of the airway integrity. Non-invasive ventilation maintains the patient's natural airway, minimizing the potential for airway damage, inflammation, and the complications associated with invasive methods. Of course, we need to mention the improved patient comfort because non-invasive ventilation utilizes masks or nasal interfaces, allowing patients to breathe more naturally and also communicate with medical staff. This promotes better patient comfort, reduces anxiety, and also increases cooperation with treatment. Also, shorter ventilator dependency is one of the key points of the non-invasive ventilation, because non-invasive ventilation can serve as a bridge to recovery, facilitating gradual weaning off ventilator support. This potentially reduces the overall duration of mechanical ventilation and also associated complications. Because non-invasive ventilation often requires less sedation compared to invasive ventilation, that also leads to faster patient awakening, better neurological assessment, and also decreased risk of prolonged sedation. Non-invasive ventilation is also applicable to a range of conditions. It is effective in managing various respiratory conditions, such as exacerbation of chronic obstructive pulmonary diseases, congestive heart failure, and acute respiratory failure. NIV is also associated with better hemodynamic stability, particularly in patients with certain cardiovascular conditions, minimizing the potential for cardiovascular complications. In the terms of the treatment options, non-invasive ventilation can offer quite flexible treatment options because it can be used in various healthcare settings, from intensive care units to general wards, and in some cases even in home care, providing versatility in patient management. Non-invasive ventilation can also be initiated more quickly than invasive ventilation, making it especially advantageous in emergency situations or when immediate intervention is needed. For the end, there is a huge potential for cost saving because due to the shorter hospital stays, reduce complications, and decrease need for resource-intensive care, non-invasive ventilation can contribute to cost saving for both healthcare institutions and patients. With these 10 key points by choosing non-invasive ventilation, we are finishing today's part related to the introduction of Heyer VG55. Thank you for your attention. Okay, so thank you all for staying with us and for going through the Dr. Mark's speech and the product introduction. Now, Dr. Mark is here with us, and we are going to go through some of the questions that we have received during this training. Also, during our question and answer, you can also come up with more questions, and they will be asked during today's part. Dr. Mark, hello. How are you today?
Hello. Fine, thank you.
Nice to see you. So we can go straight to the questions. First of the questions that we can start with is, what advice would you give to someone who is starting out with the non-invasive ventilation?
Well, I think the most important thing is to have enthusiastic, committed staff on board. I remember back in the very early days when non-invasive ventilation in the acute setting was just beginning to become part of reasonable practice, that colleagues working in intensive care units particularly saying that they really struggled with it. And part of the reason was that their nursing staff were not committed to it. It was more difficult for them. Much easier to have a paralyzed, sedated, intubated patient who's lying quietly in bed, who just needs observations every so often, the occasional tweak of the ventilator, than perhaps slightly confused patient who's taking the mask off every so often, who's moving around in bed, who needs encouragement, etc., etc. And I think it's really important that the staff, all staff, are on board with this. Otherwise, you will find that people are very quickly looking for a reason not to persist with non-invasive ventilation. Indeed, I remember one of the best units at providing NIV in the very early days was a unit in Germany that was geographically separate from an intensive care unit. And when I spoke to the doctors who ran it, they said that one of the reasons that they were so good at it was because they had to be, because when there was a problem, they had to get on and sort it out. Whereas had there been easy recourse to intubation, they very quickly would have bottled out. I think the second thing is really important to start with easy patients, not with difficult ones. Otherwise, what will happen is that people will very quickly lose confidence, or alternatively, if they don't really want to go down this route, they'll find a good excuse for not doing so. So, for instance, if we're dealing with COPD, I would start with the subgroup with a pH of greater than 7.3 and practice and learn one's skills on that, knowing that actually most of them are going to get better anyway. But there is still a 1 in 10 number needed to treat in terms of non-invasive ventilation, preventing the need for invasive ventilation. So there's a clear advantage, but if you start with the really difficult patients, you're going to have a much higher failure rate potentially, and people can be put off it. Ideally, it would be helpful for some senior staff, both medical and nursing and respiratory therapists, to visit another unit to learn from them. If they could spend a little bit of time there to actually see it over a period of time working out in practice, that would be an advantage. But I think that personal, sort of intimate personal experience is better than just going on a course. But obviously going on a course provides you with lots of useful background information as well. So I would advocate that. But I think the key focus should be on the staff, making sure that they're adequately prepared, that they're on board, they're enthusiastic, and starting with easier patients.
Okay, thank you. Next question would be, we can say like continuing for this one. So for someone who is starting out with the non-invasive ventilation, how would you set the ventilator?
Well, I think that the key thing is that the patient's got to tolerate the ventilator. And I mean, I don't come from an intensive care unit background, a respiratory physician, and I started off learning about non-invasive ventilation predominantly in the home care setting, and then translated that into the acute setting. And the advantage you've got in home care, of course, is that time is on your side. You don't have to get something to work within days, let alone hours or minutes. But I always took the view that it was better that somebody had 80% support that they could use rather than 100% support that they wouldn't use at all. And so I never went down the route of targeting a particular mils per kilogram tidal volume, et cetera, and my focus was always on getting people to use it first and foremost. So start with low pressures. But on the other hand, you also have to increase them to achieve your desired result. So there's no point leaving people on an IPAP of 5 centimeters of water when actually they're tolerating it perfectly well and could be tolerating much higher pressures more readily. And as a rough rule of thumb, I'm talking really about COPD patients here, I would be aiming for a pressure of at least 20 centimeters of water IPAP. We know that above that you tend to get a significant increase in leak. But we did a study in acclimatized patients showing that although you got more leak with higher pressures, you still got an extra beneficial increase in effective ventilation, both in terms of volumes, but also in terms of offloading of the diaphragm. So start low, but increase fairly rapidly up to 20 centimeters of water. If need be, don't be frightened of going higher, saying nobody can tolerate this. Patients can tolerate it. However, it is better to have a patient tolerating 80% of what you would really like them to give than just throwing it off and refusing to use it at all. People often ask about what level of IPAP we should be using, and indeed that's where I've started. But it's also very important to focus on EPAP. Now, most ventilators come with a mandatory low level of EPAP, but it actually does fulfill an extremely important role, and that is both in terms of washing out dead space, preventing rebreathing. It also has an effect in the COPD patient in offsetting the intrinsic PEEP that is occasioned by severe hyperinflation in COPD. And that can be very important, both in terms of improving comfort, but also improving patient ventilator asynchrony. In the patient with severe obesity, EPAP is obviously important during sleep because upper airway obstruction may be a significant factor. And you may find that you have different EPAP settings for sleep and wakefulness, such that you sacrifice some of your level of pressure support during the night, because no level of pressure support is going to be very helpful if you're trying to blow it into a completely collapsed, occluded airway. And the main priority there is upper airway control, and then augmenting it a bit with some additional assist during the inspiratory cycle. But during the day, you don't have to worry about the level of upper airway support in the same way. And therefore, you can have a lower EPAP, enough to prevent rebreathing, enough perhaps to give a little bit of volume recruitment to reduce the work of breathing, but the main focus should be on increasing the level of pressure support to improve blood gases. And I think that the other thing is that in the acute situation, backup rate isn't usually terribly important, and you can just set a baseline of 10, 15 breaths per minute. But just very occasionally in people with severe asynchrony with COPD, then actually taking over ventilation completely and going for fully controlled ventilation can be helpful. But I think that's something for more experienced, more sophisticated users. I think the key take-home messages are pressures that the patient can tolerate rather than dialing in a particular number and aiming for that. But obviously, you've got to monitor progress. What you want to see is the respiratory rate coming down. You want to see the blood gases. You don't want to leave it like that. You want to then start bringing those two down. And I would commend not having to work so hard. And again, that would be acceptable. But again, over time, you're going to want to start to correct some of the physiological abnormalities. Sorry, that's rather a long answer to quite a simple question.
Okay, thank you, Dr. Mark. Next question would be related to the palliative care and application of the non-invasive ventilation during this period. Few participants expressed wish if you could expand more on this topic.
Right. I mean, I personally think this is a very useful part of the role of non-invasive ventilation, for which there isn't actually much research data because it's quite a difficult area to study. But in my everyday clinical practice, I found it extremely useful, and perhaps useful just to start with a real life case. I remember this was 20 odd years ago, in the early days of relatively early days of our service here in Leeds, that it's more like 30 years ago now I think about it. We had a patient who came in severe hypercapnic respiratory failure, who looked to, well, in every parameter that you looked at, he looked as if he had very advanced end-stage COPD. And yet the family insisted that he had been living a completely normal life up until the day of admission. And it seemed very hard to believe this, but obviously, you have to believe what the family tell you. And we successfully established this patient on non-invasive ventilation. The next day, some different family members turned up who told a very different story. And that basically he hadn't been out of the house for months, he was totally miserable by his condition, etc., etc. And that the difference was that the first group were largely comprised of people who hadn't really had anything very much to do with him, now felt guilty about it, etc., etc., whereas the second group were those who were actually in day-to-day contact with him, looking after him. And what we were able to do by that time, he was semi-conscious when we first started, that we were able to speak to him. He told us that his life was totally miserable, that he didn't want to go on, he didn't like the non-invasive ventilation, he didn't feel he had any reason to carry on living, etc., etc. And we gradually withdrew ventilation and he died peacefully. But I think that the key message there is that had one's only option been invasive ventilation, that one really would have felt compelled to intubate this patient on the basis of what the original group of relatives had said, whereas in fact this was totally contrary to what he would have wanted, and also contrary to what we would have thought to be appropriate in that situation. I said that NIV gives you the option of backing both horses, that it is an effective life-sustaining therapy, but it also palliates. And the way that I would use it is that if you had a patient with advanced disease, that we would offer it to everybody, and if in doubt, we would ventilate non-invasively. And this is all done outside an intensive care unit on a respiratory high dependency unit. We would give 24, 48 hours and see how things were going. And if it appeared that despite effective application of non-invasive ventilation, so a well-fitting interface, good synchrony between patient and ventilator, that what we're looking at is a patient who is failing ventilation rather than failing non-invasive, we'd start to discuss with the patient and their family how they wanted to take things forward, explaining exactly where we were. And my usual experience was, and what I would say to people is, look, up to the patient is up to now, we've been telling you that to put the ventilator on, and we haven't really given you much choice in that matter. What we're going to do now is we're going to leave the ventilator by your bed. It's there, but if you want it, we're going to wait for you to ask for it to be put on, the mask to be put on, the ventilator to be connected. And what usually happened is they didn't ask. And I'd also, explain to them that if they felt very breathless, we would offer them a small dose of opiate, etc., to palliate their breathlessness. And what usually happened is that they didn't ask. And so 24 hours later would say, right, you haven't used the ventilator now for 24 hours. What we're going to do is take the ventilator away. So it's no longer by your bed. If you want it back, all you have to do is to ask one of the doctors or the nursing staff and we'll get it, but we're going to take it away. And what we would also do at that stage is try and take away the oximeter. because it would be very difficult for the family looking at low oxygen saturations, or sorry, do that at the previous stage, say we're now going to take away the oximeter, because otherwise what happens is you get the family rushing around saying the oxygen levels are falling, etc., etc. And we'd be more generous, we'd be less worried about giving higher flow rates of oxygen, etc., etc. But I found it a very useful way of managing the transition from supportive, essentially life-saving care to a much more palliative approach, and that the patient is able to be involved in that discussion. And of course, there are some who wanted to carry on, saying, no, don't take the ventilator away. I do want to carry on with it. So I think it's a very useful thing to have. And I think certainly in the UK setting, there are some patients who would be denied admission to an intensive care unit who are given the opportunity to actually have a few more months of reasonable, at least in their eyes, reasonable quality of life. So I think it's a very useful adjunct, very useful thing to have as an option, and gets you out of some quite tricky situations at times.
Thank you for this one. Let's move to the next one. The question is, what complications associated with non-invasive ventilations are more common from your experience?
Well, I think there are remarkably few, actually. I mean, I think the big one is problems with the interface, the mask, and that's usually due to inappropriate mask selection, over tightening. We used to see it a lot in the early days because the masks that we had were not very good in terms of what is now available. So leak was a big problem. So there was a big tendency to over tighten them. So you could often tell the patients who'd been in hospital for any length of time on NIV because they'd got a little ulcer over, or some redness and soreness over the bridge of their nose. But that now is very unusual in my experience. Likewise, when we used to use volume ventilators, we used to see, particularly in the COPD patients, problems with abdominal distension when using high inflation pressures. But again, one just doesn't see that these days with pressure limited devices and generally more efficient devices used at lower pressures. I said that most of the published contraindications were actually exclusion criteria for the clinical trials. And you mentioned this question of hemodynamic instability. And I absolutely agree that it was always an exclusion criterion for the non-invasive trials, that you shouldn't use it with hemodynamic instability. Well, I have never in 35 years of practice in this area seen doctors standing around a patient's bed squeezing bags of fluid into the patient, trying to get the blood pressure up when they're on non-invasive ventilation, whereas I have seen this in patients receiving invasive ventilation on paralyzing, sedating drugs, etc. So I think that the implications for the circulation are actually much less with the non-invasive approach. And I think that what one has to remember is that there's actually a very significant attenuation. It's a big pressure drop across the upper airway, that what is actually being delivered to the lungs and to the intrathoracic cavity is much lower than the reading that you see on the ventilator. A lot of the pressure drop, there's a big pressure drop across the upper airway, etc. I suppose the biggest side effect complication one sees is people who don't tolerate it. Whether that's really a complication, I don't know. A significant proportion of those can be persuaded to tolerate it. Again, I've had patients who say they don't like it, they don't want to use it, and have been explained to them that, you know, with a pH of 7.2, the alternative is rather worse. And particularly those who are particularly easy to persuade are those who have been intubated and ventilated before, who the process of coming off the ventilator, waking up, etc., with a tube down your throat is not very pleasant. That they usually say, well, if that's the alternative, then actually I'll put up with it. There are others who just don't want it, can't cope with it, and that no amount of persuasion, etc., will persuade them. Really important to make sure that their complaints of it being uncomfortable and horrible and not justified, as I mentioned, that make sure that the mask fitting is as good as it can be, make sure that the headgear is fitting well and is the right headgear for the interface, make sure that there are ventilator settings that are appropriate to their needs, and that you're not actually making them worse with the ventilator rather than better. But I think complications are actually remarkably few. And as I showed, and as you mentioned, infectious complications are much reduced. So the problem is that when you intubate a patient, you solve one problem, you create others.
Okay, thank you so much. And I think we do have time for one more question. The question is related that nowadays there is a variety of different kind of the ventilators of the market. So what kind of the ventilator would be best choice for medical staff who are focusing on the non-invasive ventilation?
I think it has to be a ventilator with a specific, either specifically designed for or with an NIV mode. That in the early days that standard ICU ventilators were used, which obviously didn't have a mode specifically for NIV, and counterintuitively these were actually shown to be inferior to some fairly simple rudimentary home ventilators. And the reason really is about the ability to compensate with leaks, which are a much bigger issue with a non-invasively ventilated patient than with a ventilated patient. I think that you want a ventilator that the staff are familiar with, that what you don't want on any unit is lots of different ventilators with different sets of instructions as to how to turn them on, how to change the settings, how to get to different monitoring screens, etc., etc. And familiarity is an enormously important part of all of this. And obviously at the beginning it's important that staff are trained about how to use the ventilator, that just getting a non-invasive ventilator to have a go is probably going to end up badly, because people won't be familiar with how they change things. I think that you also want a ventilator that is, again, it depends on exactly who is using it. But if you are using it in an unsophisticated environment, by which I mean people like me who are pulmonologists, who are not ventilation, mechanical ventilation isn't part of our day-to-day job. You don't want too many parameters that I can fiddle around with and get wrong. If, on the other hand, I am a skilled intensive care doctor who is dealing with ventilators every day and is used to fine-tuning subtle parameters, etc., then the ability to do that is an advantage. But I think the most important thing is that the ventilator needs to be fit for purpose and that the staff need to know how to use it.
Okay, thank you, Dr. Mark, one more time. And thank you, first of all, for a wonderful lecture, and thanks for answering our questions in this session. For our participants, thank you for participating in this webinar, and thank you for staying with us until the end. Wish you a pleasant day, and hope to see you next time on the next occasion when we will organize some webinars. Thank you one more time, and see you next time. Goodbye.
Thank you.
Thank you.
Good night.